So hi, my name's Nanette. As Jenny's kindly introduced me, I'm a physio. I work predominantly at Chesterfield Royal, and then I do a clinic with Mr. Bryant and Mr. Charney every 6 weeks at the Sheffield Children's Hospital. So I just wanted to start by saying my background is predominantly adults. When I started at Chesterfield about 8 years ago, I started seeing some of the children with shoulder problems, and then I was kindly invited to go to the clinic at the Sheffield Children's Hospital with the consultants, which extended my interest in children and shoulder problems further. And I have to say it's been a steep learning curve, and I'm still learning, but I'd like to share some of the bits and bobs I've learned over the last few years to hopefully give you a few ideas on how to treat the paediatric shoulder, and this is from a predominantly musculoskeletal point of view. So the aims of the in-service, I'm going to briefly outline the functional anatomy of the shoulder girdle, to give a brief overview of the common musculoskeletal conditions seen in a paediatric upper limb orthopaedic clinic, and then hopefully to gain an understanding of how to assess and treat these conditions. So first of all, just a bit of a revision on the functional anatomy of the shoulder. So it's quite a complex joint. It's an inherently unstable joint. It's a large ball on a tiny or on a small socket. It's deepened by about a third by the labrum, and this acts as a chock block to keep the humeral head in. Other static constraints include the capsule, which is quite capacious, and the ligamentous structures, which are predominantly the superior, middle and inferior glenohumeral ligaments. The dynamic restraints are the most important for the dynamic stability of the shoulder, and these are the rotator cuff and deltoid, and also the long head of biceps, which acts as a compressor of the humeral head. Just a little bit more of a reminder about the muscles around the shoulder, and I'll talk about these and their role a little bit later on. But the ones I tend to concentrate on more are the rotator cuff muscles. You might hear me talk about the posterior rotator cuff, and by this I mean the supraspinatus and infraspinatus muscles, and then the anterior cuff, which is the subscapularis. The other muscles that are particularly interesting around the shoulder and we talk about are the latissimus dorsi, which is an powerful external rotator, the pectoralis major, and also the deltoid. So we'll come back to these later, but just to give you a bit of a refresher. So just to say what we commonly see at the Sheffield Children's Hospital. So it's a clinic that runs every 6 weeks. So it's not a weekly clinic because the conditions are not that common overall. It's predominantly things that might be treated arthroscopically. So we see a mixture of traumatic and atraumatic shoulder instability, scapulothoracic crepitus and dyskinesia, sternoclavicular joint atraumatic instability, and then numerous elbow conditions, including OCD. So I wanted to kind of talk about the unstable shoulder in general and what actually am I seeing, and trying to pick apart what you see and then how this can influence your management. So I've got a couple of videos which I'm hoping will play. So I'll go through these later, but I just wanted you to have a look and just see what you think you might be seeing. I'll just play that one more time. This is very typical of what we see at the Sheffield Children's. And then the next one. So all I'm asking this girl to do is just externally rotate her shoulder. And then I'm just moving her arm away just to see if I can see what muscle she's actually using to get this abnormal movement pattern. So we'll come back to those later, but just to get you thinking. So from an assessment point of view, it's thinking about the key subjective history, and this is with particular reference to shoulder instability, key objective markers that you might look at, and this is for both assessment of the traumatic shoulders and the atraumatic shoulders. and what is particularly relevant to the assessment of the unstable shoulder girdle. Thinking about, do you need to send for any investigations? How do you rehabilitate once you've had once you've fully assessed the patient? And then when do you need to think about an MDT approach? So the first thing to think about is actually defining what is an instability versus a laxity and where to begin. So the best to think of joint laxity implies a degree of translation of the glenohumeral joint, which falls within a physiological range and is asymptomatic, so the patient doesn't get symptoms. Instability is abnormal and pathological and produces symptoms such as pain or apprehension. I think it's sometimes a little bit confused in terms of assessment, so it's just to kind of think about that before you assess. So classification of shoulder instability is difficult and there is no consensus. However, in the literature, it's important to consider the following things. So etiology, whether there has been a traumatic episode in terms of a fall or an injury playing sport, or whether there has been no history of trauma and the patient just describes the shoulder starting to pop or displace, but there's been no injury. How severe it is in terms of subluxation or dislocation. Is the shoulder fully dislocating or just slipping? And I think sometimes it is very hard to differentiate clinically. Some people may describe a dislocation, but you don't actually know whether the shoulder has come out or not. And this can sometimes happen playing sport as well, where the patient's fallen and it's been relocated as they move their arm up. The relevance, it's how relevant it is as well. And then the history, so is it an acute injury or an acute dislocation you're treating, or has it been going on a number of years? How frequently it's happening? Is it a daily? Is it every time they move their arm? Or is it just when they're playing overhead sports? Or have they just had one episode and then come to physio? Associated symptoms, including apprehension, reduced movement and or pain, whether they're getting any clicking or any sort of neuropathic type symptoms. And then how volitional it is. So can they control the dislocations? Do they happen just on when they think about it, such as doing a party trick, or do they have no control over the dislocations at all? Or did they start off with being able to do a party trick as a kid and it wasn't really a problem until they reached adolescence and suddenly the shoulder started to become into an unstable pattern where they couldn't control it and it becomes more problematic. So what we use in clinical practice is something called the Stanmore Triangle classification, which was devised by the specialist down at the Royal National Orthopaedic Hospital in Stanmore. So this classifies nicely the shoulder instabilities into 3 types. They talk about the polar type 1, which is shoulders that have had a traumatic episode and have an underlying structural lesion. Type 2, which is atraumatic or very micro trauma, but they do have a structural problem inside. And then the polar type 3, which are the muscle patterning type shoulder dislocations, which when you look inside the shoulder have absolutely no structural damage. Patients can move in between these patterns. So for example, a type 3 who recurrently dislocates over a number of years may start to get some structural problems. Likewise, a type 1 who has had an injury and maybe has had some sort of structural deficit and then starts to develop abnormal muscle patterning on top of this. So they can be combinations, but this is kind of the best way we use in clinical practice to classify them. I'll go into these in more detail and also give you some clinical examples. So type 1 are the most common. This accounts for 95% of all shoulder instability. There is a clear history of trauma, such as a fall onto an outstretched arm, and that's typically with collision sports such as rugby or football. The patient will describe often severe pain or intense pain for that moment, of feeling like the shoulder is out of place, and then they move it to put it back in, either on pitch side or it's relocated on pitch side, or they have to come to hospital to have it relocated. So typically these patients often have an X-ray with the shoulder dislocated if they have come to hospital. There's often an associated structural lesion, which we'll go on to, such as a Hill-Sachs, which is a deformity of the humeral head, or some damage to the labrum. If they're a polar type 1, they don't have any abnormal muscle patterning, and it's often usually unilateral because it's the side they've fallen on. Type 2 atraumatic, so type 2 and 3 become a little bit harder to classify, and they account for around 5% of instability. So this may be microtraumas such as the throwing arm or the swimmer or repetitive injuries. So there is some minor structural changes. It's usually unilateral, and there may be some capsular dysfunctions such as hyperlaxity, but again, there's no abnormal muscle patterning. Type 3, there is no history of trauma. The problem often comes on over a period of time, and they notice the shoulders starting to pop and sublux. Often initially they don't have pain. Common age of presentation to healthcare is around 14, and this may coincide with puberty and growth spurts. Inside there is absolutely no structural damage to the muscles or the cartilage, but they have evidence of abnormal muscle patterning. It's often seen bilaterally and often associated with hyperlaxity. So how do we classify the shoulders? So a few key subjective questions that I like to ask. So the first one is the presence of absence of any trauma, and that's the key thing. So even if they've started to come out really frequently, was the first time it ever came out, was there any history of trauma? Because that increases your index of suspicion of a structural lesion. Was there a voluntary or involuntary history? So a lot of the kids I see have maybe done it as a party trick when they were younger, or they used to pop and click their joints, wasn't particularly a problem. And then when they when they start to grow and their skeleton grows and their muscles don't catch up, they often start to get an involuntary pattern. And that's when they present to physio because it's becoming a nuisance. Do they have any other symptomatic joints? So generalized hyperlaxity, such as in their hips or knees. And what was the age of onset? So was it around puberty? I see a lot of kids around kind of 11, 12, 13 as they're hitting a growth spurt or changing their activity levels. What's their sporting background? So are they particularly sporty? Do they do sports that may predispose them, such as throwing, gymnastics? Swimmers do, especially in Sheffield, do a huge amount of swimming. And then consider the social background, so family dynamics, family support, and what's happening at school. So especially with the type 3s, I might start to look for other drivers for the dislocations. So any pattern with increased frequency of dislocations either at school, with less at the weekends. I might not ask this on the first appointment, but I look for any problems with bullying or any kind of psychosocial issues which may be contributing to it. So symptoms, so characteristics of the shoulder dislocation. So I think direction's sometimes quite difficult to ascertain. The most common is a posterior instability. Sometimes you can see that. Is there a clear direction? That may point you in the direction of which muscles are at fault. Do they have pain? So a lot of the children I see initially don't actually have many symptoms at all. It can feel a bit unpleasant, be a bit annoying, but pain's not too much of an issue. If they are reporting lots of pain and odd sensations or neuropathic type symptoms, that increases my my thoughts about other drivers going on and the complexity of the case. How easily is it coming out? So is it coming out when they're playing sport, when they're using a tennis racket in their arm above the head and very infrequently, or is it coming out either at rest or every time they move their arm? Generally, the ones that it's harder to dislocate and it tends to be in extremes of position generally respond to treatment much quicker or easier than the ones that are coming in and out very easily. And this is the same with the frequency. And then the impact on life. So has the child stopped PE? Are people quite wary of the dislocations? Is there a lot of fear and around the dislocations? What's the school's reaction been to it? Have they been stopped from doing PE? How does the child feel about this? Impact on social life? Or do they just get on with it and school lets them get on and they kind of pop in and out and it's not a problem? Again, there's lack of consensus on which PROM to use. I tend to use the Oxford Shoulder Instability Score, which is quite good at giving measures of apprehension and not just pain, but there isn't a clear consensus of what to use. So from an objective examination, I'm going to talk about kind of what I'd look for in a general shoulder exam, thinking more about ruling out a structural problem, and then we'll go more on to thinking about the type 3 and the muscle patterning, and a few tips and tricks of how to spot and what to do with it. So for the first thing I do is observe how the child moves generally, how easy they are taking their clothes off, if they use the limb normally, if there's any muscle wasting or asymmetry, any evidence of scoliosis or kyphosis. I'll palpate along the clavicle and the AC joint and just have a general feel of how sensitive they are and if they're pretty happy with me, and no kind of hyperalgesia. I'll then look at the range of movement, both in terms of the degrees of how far they move, and then also the quality of the movement, how willing they are to move, and if I can kind of start to pick up any evidence of abnormal muscle patterning in comparison to the other side. I'll look at strength testing, which I'll go through in a minute, and then looking at just laxity versus instability tests to rule out any structural issues or underlying hyperlax joints. And then I'll go on to my symptom improvement testing if it's relevant to the patient. So just a quick reminder of the rotator cuff test. We know that we can't particularly bias certain muscles, and that all muscles work in all ranges, but they will still teach us in orthopedics, and I think there is some use to them. So typically you've got external rotation resistance in neutral. For infraspinatus, you've got the supraspinatus test at the bottom, and then on the right hand side you've got the test for subscapularis, which is the lift off, belly press and bear hug. So they just quite crude measures of strength. I like to assess the cuff more dynamically, which I'll go through in a bit, but they're just kind of basic baseline measures. So for structural, for structural pathology, what we're looking at is trying to screen the labrum. So we think about the labrum and the glenoid like a clock face. So the superior aspect is where you're at the top, the inferior aspect is the bottom of the glenoid, the anterior superior is at the front, and then the posterior superior and inferior is at the back. And surgeons will classify when they're operating like on a clock face where the damage is. So they might say the labrum's been repaired from 4 till 7 o'clock or from 4 till 10 o'clock, so you can gauge how much damage there's been. And so our tests will look at the labral pathology. So a Bankart is essentially looking at the anterior, inferior and inferior aspect of the glenoid, the glenoid labrum. A slap tear by definition is a superior labrum anterior to posterior, so that tends to be the upper half. And so we hope to bias with our tests the different parts of the labrum. And how we do this. So there's a test called the Gage's hyperabduction test. So this can be used both for laxity and for inferior stability. So essentially, it can be used if you get a bilateral positive. So normal shoulders are around 100 degrees of hyperabduction when you just test passive hyperabduction. In a hyperlax patient, they may get up to 140 degrees of abduction bilaterally. If it's unilateral, it's indicating a deficit in the inferior part of the glenoid labrum. And so if you get 140 degrees bilateral, it indicates hyperlaxity normally. And if it's unilateral, it's deemed a positive test for a structural problem. Most of you probably know the apprehension relocation test, which is looking more for your anterior stability. You test this in supine, take the shoulder up into 90 degrees for external rotation, and then add an AP pressure. The test is only positive if they get apprehension. Pain is not a positive test. And then when you apply the pressure down, the patient generally feels more comfortable. So if a patient is a type 3 and coming out of joint all the time, they generally won't be apprehensive in this position. You can move them in and it just doesn't bother them. If they have sort of labral problem, they just don't like going into that position. And then posterior instability, you've got the Kim test and the jerk test, which essentially loads at the back of the labrum, and again it's positive if it's pain or apprehension. And then the SLAP test, there's many SLAP tests. We tend to use the O'Briens in clinic just because we can do it with the patient standing, and essentially you take the hand into a cross-body movement, apply a pressure, and if they get pain, you then get the patient to supinate their palm. You apply pressure again, and it's meant to be stronger and less painful. It can use the AC joint as well, so use it with caution, but all these tests together just build up a picture with the clinical background as if there's any structural underlying instability. So that's just a kind of a reminder of instability versus laxity. So laxity test would be your Baton score, which is, I'll go on to in a minute, sulcus sign, Gage's test, which is bilateral hyperabduction. And then your instability test, you're looking more at the structure of the shoulder joint itself. So the top picture shows a sulcus sign. Just put a couple of images of what hyperlaxity can mean, and that it's not pathological, and a lot of our gymnasts and sports people are hypermobile. And then just a reminder of the Baton score, which a lot of kids score highly on anyway. So it's just building up a picture of generalized hypermobility. For hyperlaxity in the shoulders, we tend to use a score out of 3, which is Gage's is being 1 score if so they score 1 if they have got hyperabduction of more than 140 or more than 105. And then we look at external rotation in neutral of being over 90 degrees, and then external rotation in 90 degrees abduction of being over 90 degrees. And so if a patient scores high on that, we would say they're 3 out of 3 on the shoulder hyperlaxity. So case 1, so I just thought I'd talk through the types of shoulder instability. So this is a type 1 case study. These aren't actually the images. I saw this girl quite a while pre-pandemic, but she fell over skiing when she was 14. She dislocated a shoulder. It was relocated on the side of the slope. She came back to the UK. She had some rehab under physio, but she couldn't get back to playing netball and was still experiencing apprehension in throwing position. She came into clinic. She had positive apprehension relocation test and positive SLAP test. And then she had an MR. So the investigation of choice is an MR arthrogram that puts a dye inside the shoulder as they scan it and shows up a labral lesion. So this is a real classic type 1 case. She had no muscle patterning, she had full movement, very little pain day to day, could get on with day-to-day life, but had this clear traumatic history. And whenever she tried to get back to her overhead sports, she felt quite vulnerable. So by the time we saw her, she was 15. She had a SLAP tear and a labral tear when they went in with an arthroscope, which was repaired. She then just followed the post-op protocol, which was 3 weeks in a sling, protective mobilization for the first 6 weeks, and then supervised strengthening up to 12 weeks, and then sports specific from 12 weeks plus. And she got back to her sports with no further instabilities. So that's kind of a really kind of clear type 1 instability. I just thought I'd put in the surgeon's perspective at this point, just so you get an idea of numbers. So at Sheffield, we cover Yorkshire and Humber, South Yorkshire, Derbyshire, Rotherham. So pre-pandemic, the conversion to surgery for shoulder instability was 20 cases over 5 years. The large proportion of them go to physio, and we tend to manage them as rehab, so they don't operate. Even if there is a structural problem, if they've only dislocated once, we tend to go for rehab, unless they're really, really sporty. And it's usually offered in the age 15 to 18 sporting group. The youngest patient that there was ever had a keyhole surgery was a 13-year-old, and they had a what we call a panlabral tear, so a 360-degree tear, and was grossly unstable. And then we've had one bony procedure, which is called a Latarjet, and again that was for a collision athlete who, when they went in to repair it arthroscopically, had no labrum to repair, so he ended up with a bony. But that's 1 in 5 years, so the numbers are quite low, really. And then Mr. Bryant wanted me to point out that don't rule out a structural pathology if there is associated hyperlaxity. We've had a few recently that have presented very much like type 3 instability, with kind of muscle patterning. I've been treated by muscle patterning physio for a number of years. They've done an MRA and they have had some underlying structural problems. So the key is that kind of initial episode of trauma. So it's just to bear in the back of your mind. So type 2 case study. So this was a 14-year-old competitive female swimmer. She came to me with a 12-month history of bilateral shoulder pain, right being worse than left. She hadn't had any change in her training up until that point, but she was currently not training. I think she was on the Sheffield Olympic training program, but she did have a growth spurt associated at the time of the onset of a shoulder pain. And she was at 5'11" when she saw me at 14, so she was a tall girl. So on clinical examination, just these kind of few things that I'd picked up. So she had quite a poking chin posture with winging scapula bilaterally. She did have hyperlaxity in her shoulders of 3 out of 3, but Baton score is actually 0 out of 9. I felt that she was just functionally weak through range of rotator cuff and also her upper trapezius, and she had generally poor core stability. So from a rehab point of view, we looked at her core strength. She didn't do any dry land training at the time. Looked at getting her some scapular stability exercises through range, and then also worked on rotator cuff control and general conditioning. So it's just to say with this patient, she did really well initially. After 3 months, she decided she wouldn't go back to swimming, and she actually changed and went into coaching. So her activity levels went down generally. And then after 3 months, she came back to me with increasing pain and symptoms. She was kind of getting to GCSE years by this point. She was spending a lot of time sat revising. Her activity levels had reduced significantly, and she was quite concerned about her shoulder. She was getting more pain, more clicking. I think she'd grown a little bit more. So reassessed her, and she had kind of her scapula had started to kind of wing a little bit again, and she was quite hard to engage the second time. And despite the fact that there was lots to treat objectively, we could show her that her cuff was quite weak. I just felt that she wasn't kind of compliant with physio as much as she was the time before. So with her, we actually liaised with the Sheffield Children's Hospital. She did have symptoms of an irritated SAP, but I felt this was more as a result of her reduced rotator cuff activation. However, she had an MR arthrogram at the Children's Hospital, which was normal, and this seemed to give her a bit more reassurance. And after that, she did engage with physio, had a good solid 3 months, and was then back up to full strength, full mobility, and no pain. So some of these patients do need to kind of persevere with their exercises a little bit longer, and sometimes investigations do help just to give the patient some reassurance. This is not that patient, but this is just an example of some work with TheraBand I might do. So essentially, I was using the TheraBand. This patient presented very similar to the girl, and he had full movement, but he had pain on movement, and I could see when he was moving his shoulder, he wasn't really recruiting his upper trapezius, his cuff wasn't really firing, and so I just used the bands to try and activate his muscles a little bit more, and I just played around with the whether he preferred an anterior or posterior direction with the band, and he seemed to really like this, and I just got him to mimic the movement at home, and this became part of his rehab, which helped. So it's just to kind of give you an idea. So, sorry, going on to kind of objective tips and tricks for more of the type 3 instabilities. So half the battle is identifying the abnormal muscle patterning, and then can you change it? I also tend to look a little bit more into the core stability side of things. We know that poor core stability can influence the superficial torque action of the larger global muscles such as lat dorsi, and they can in self result in poor control of the shoulder. And so I tend to use stability in the kinetic chain when looking at the shoulder. So typically core stability tests I might look at Kibler's corkscrew, which I've got a video of next hopefully, and then just general functional tests such as how well they can perform a step up, a lunge, can they do a bridge, can they do a single leg bridge, so just looking at their core and proximal control. And then developmental tests, so Joe Gibson up at the Liverpool unit taught me about these, and they're just looking at whether there's any developmental delay that might account for why they are moving their shoulders so abnormally. So she talks about the angels in the snow, and then looking also at the rolling, essentially how you would teach a child to roll. The angel in the snow is looking at all 4 movement of the limbs and whether they can move their arms and legs and differentiate between the two with no associated movements. They can coordinate the movements, and then looking at the hesitation and whether they need to look at what they're doing. So it just adds a little bit more of a dimension to your assessment. So I was talking about functional functional assessment of the rotator cuff, and some work done by Anju Jaggi down at Stanmore. I'll just play the video. So essentially you get the patient child in prone, and you're just looking at how well they can control external rotation and medial rotation. So you're looking at how well the cuff, both anterior and posterior, can function in its inner and outer ranges. And then I'm also looking at what the scapula is doing and whether they're compensating or having to lift the shoulder off, and how much the glenohumeral joint is moving as well. I always compare it to the other side to see whether it's a bilateral problem, and how easily they can move it. And often it's quite good just to show the patient if there is a difference, because they just feel how different it feels from side to side. And then you can also resist it just to see how well they can control it. And here it's supported. You could also do it unsupported. That will then add some load as well. And then this is the corkscrew test. So he's laughing because we asked him to, this is our student, this was he didn't have to fake it, so he has actually got quite poor control over his left side, and he is slightly better over his right side, so it's just quite a nice way of just looking at their proximal control. Sorry. And then observing for abnormal muscle patterning. So just looking at how the child flexes their elbows. So you just get them standing, get them to bend and straighten their elbow, and do they activate their pecs? So you shouldn't activate your pecs if you're just bending and straightening your elbows. So if they are recruiting their pecs, it's maybe starting to think that they're a bit pec dominant. And then if you then get them to flex their shoulder, you can often see the pectoralis major really kicking in with that movement. So you look at shoulder flexion as well. Shoulder external rotation, so you just get the patient to rotate their arm outwards. And what I'm looking for is whether they're kind of really kicking in their lats. So you can tell this I don't know if you can think back to the video I showed you with the girl with the quite abnormal muscle patterning. I just kind of pulled her arm away from her side, so I was just seeing whether she was clamping her arm down. So typically patients that use their lats a lot, they'll kind of clamp their arm into the side, and you can really feel their lats kicking in, and their external rotation is often quite poor. So if you can get them to unclamp and just see whether they can externally rotate. If they still can't do it, I'll probably take them into supine with their arms supported and see whether they can do it then as well. Similarly with shoulder flexion, I've had children that have been referred with stiffness when they've which always kind of raises slight alarm bells because children aren't usually stiff. And often what's happening is that as they flex the shoulder, and if you look at them just from the front, they look like they have a block to movement, and you try and passively take it further and you think, oh, it's not going as I want it to. Then if you go posteriorly, you can then palpate the lats, which are really kicking in, and it's actually that's preventing their shoulder moving further forward. Like with the abduction, you can get a similar pattern. Or you might see the shoulder posteriorly subluxing at that point. So it's really looking at how somebody is moving. Once you've seen that, it's whether you can improve the patient's symptoms. So there's a few kind of tips and tricks. So firstly, you'd perform the objective test, so the movement or the strength test. You might notice that the scapula there's some dyskinesia, or that the symptoms are coming on, or that they have a range of movement or strength deficit, or you notice that humeral head subluxation. So the first thing you can do is manually assist the scapula or the humeral head, so essentially correcting the faulty biomechanics. And then at the same time reassess the movement. So for example, if you test external rotation power and you see the scapula starting to wing and they're in quite a protracted downwardly rotated position, sometimes just by facilitating the scapula, giving a bit of upward rotation, getting the traps to work a little bit more, if you then retest the cuff, they've suddenly got full cuff power. And so it's not a weak cuff issue. It's a scapular driven or a motor control problem. So that's kind of the scapular assistance. You can assist it through range, or you can just assist it in the neutral position. Posterior cuff facilitation. So by getting you to getting the patient to switch on the posterior cuff, and by this I mean you can either just get them to externally rotate their you can either get them to just externally rotate their arm a little bit, because some patients will lift their arms in medial rotation, and just getting them to externally rotate, switch on the posterior cuff. Or you can give them a little bit of resistance, so either with your hand or a TheraBand, and that can often just get the cuff firing, and that will make them feel a bit better and help to depress the humeral head and give them some stability. Getting them to use a kinetic chain, so a step stand type movement. I've got some videos I'll go through in a minute. Preventing trunk side flexions, if they're particularly lat dominant and they pull down on that side. If you try and switch lats off and get some elongation to release the scapula, that can help. And then also preventing thoracic flexion. So I've got a few videos. So again, I've just got the student to demonstrate. So patients will typically come in, they're a bit kyphotic or they're a bit slouchy, they lift with their arms in medial rotation, and sometimes that will mean that the posterior cuff isn't switching on, and then they get a posterior subluxation. So just by getting them, I think this is the video that doesn't work. Yeah, so this video, I don't know if you can see my cursor, but essentially just get them to lift their thumbs up. And then what he did was he reached his arms upwards as he stepped forwards. And often if you do that with patients, the muscle patterning will improve. And I've got a couple of case videos in a bit. Here's just an example of scapular setting. So typically I'll kind of work on the medial border at the scapula and get a bit of upward rotation, and try and get the upper traps, as well as getting the kind of the thorax up as well, and just see whether that helps them. If you see that, this is getting the kinetic chain working, you're getting some posterior cuff activation, getting glutes firing up. So often the more dynamic you can make your exercises, the more the more proprioceptive input, the more cuff input, the better these patients are. If they're say, slight caveat, if they're fairly simple, straightforward muscle patterning patients. So just to go into kind of the common patterns we see, I think by far the most common I see and this has actually been supported in a recent study, is the involuntary posterior dislocators. So the positional ones are where they are dislocated at rest. If I see that, alarm bells do start to ring, and I think they're generally a much harder group to treat. So this picture shows a persistently inferiorly displaced glenohumeral joint, which can prove difficult to manage. It's likely to indicate a gross inhibition of the rotator cuff and deltoid, which is likely to be centrally driven, and we'll go on to that a little bit. The non-positionals, so the ones that occur with movement, I think are much I would say easier, in inverted commas, to treat than the positional ones. And typically you see patterns where if they're coming out anteriorly, you've got pec major being the dominant muscle and subscat being underactive, or if they come out posteriorly, that lat dorsi and teres major are overactive, or they might just have underactivity of the posterior rotator cuff. And actually lats aren't particularly firing, it's just more inactivity of the cuff. And this has been shown with some EMG studies, but there's kind of needs to be more research. But the research state does kind of support anecdotally what we see in clinical practice. So this was just quite a nice study that's come out recently, which showed a lot of the patients that are seen tend to be the posterior involuntary dislocators. The groups that you can see this, the controllable positional don't really present to healthcare because they control it. It's only in certain positions and it just doesn't tend to bother them. So these are just some examples of what it looks like to be anteriorly subluxed. So if a patient comes into clinic, so they can have X-ray evidence of a subluxation, but it's not dislocated. So it just kind of teeters on the edge of the glenoid. So this is a girl that, if you remember, we saw her at the beginning. Let's see if this video works. So this is a fairly typical involuntary posterior instability. I'll just play that again. So she didn't really have any lats overactivity. It was just her cuff, posterior cuff, just wasn't really functioning. She hadn't had problems for that long. She didn't really have much pain. She wasn't really massively bothered by it. And literally all we got her to do, was just externally rotate her hands. We gave her the step up with the band. I think I gave some core stability, and I think within 3 sessions she was better. So she was really nice to treat. The other case I had is a more recent case who, and this is sometimes more typical of what I see in clinic. So he'd had a 3-year history of right shoulder pain and popping. He'd had no trauma. His symptoms were worsening and he was starting to get tingling in his right hand, but predominantly his little and ring finger. He was getting quite depressed about it. He didn't feel believed. He felt that he was wanting to do joinery, and he felt that it was going to affect his chance of a job because he couldn't function. He'd lost a lot of weight. He was getting gastro problems because he was taking too many painkillers. He went to A&E eventually. He told him he had a trapped nerve and he was referred to physiotherapy. He had around 6 months of physio for his neck because they thought he had some neural symptoms which basically made him worse. So when he came to see me, he had posterior subluxation in his shoulder, and he had an underactive rotator cuff, and he was posteriorly dislocating as he lifted his arm up. He was a very slim build. He had Baton score of 6 out of 9, shoulder hyperlaxity of 3 out of 3. And he was, on testing his rotator cuff, he had good isometric cuff power. So it wasn't particularly a strength problem. It was just that he wasn't activating the right muscles. And this is something else you can see. Some people have good strength, but they don't have good control. So this was just going back to the girl who, all I got to do with this one was medially rotate and do, and if you can see, but she's kind of stepping and reaching, and her shoulder didn't come out. And then as soon as I got her to just lift her again in medial rotation, pop. So it just shows how easy it can change. And then what you do is you just get them to practice getting the posterior cuff activated, lots of proprioceptive exercises. So with this posterior dislocator, this is kind of the program I gave him. So I get a lot of the stuff from the Liverpool shoulder unit, and they've got a really good website if anybody wants to look, which is Liverpool Shoulder Clinic, with some great YouTube videos and fantastic exercises. And so essentially you're weight bearing through the limb, you're getting the posterior rotator cuff to work, you're using the whole kinetic chain, you're getting the core working, and it's giving them something else to think about as well. So even the kids who dislocate just raising their arm, if you get them over a gym ball doing a handstand, they don't dislocate, and that can be quite empowering for them, and they can see that they can do something really high level and their shoulders okay. This one is called Drop and Catch. This is from the Derby Instability Programme, which is another kind of evidence-based treatment program for atraumatic instability. This is one of the first exercises I give people. So it's called a drop and a catch. And essentially you get them to drop and catch a 0.5 kilogram to 1 kilogram weight, and they have to do it for 100 repetitions. Once they can do that, they stand on one leg and do it, and then they do it with eyes closed, and then you can kind of progress them up. But it's kind of getting them to think about something other than their shoulder. It's proprioceptively rich. It's getting them to think about its joint position sense. And then this is, I call it the Superman. I'm not sure what it's meant to be called. But I find this is a really nice one for posterior instabilities. So I get them to put their feet on the back wall, and they have a gym ball that they're lying on, and essentially I tell them to kind of launch themselves like Superman. The key with this is that they kind of reach their arms up in external rotation. So again, it's lots of kind of posterior chain, posterior cuff, and they don't dislocate generally. And similarly, this is another one from the Joe Gibson Liverpool site. So you've got the gym ball, which gives lots of proprioceptive input into the thorax. You get them doing a squat to incorporate the correct kinetic chain, and then the loop band. You don't have to use a loop band, but that gets them reaching up with their arms in external rotation. So this lad basically went away. He did a month of doing these exercises, and I told him to stop volitionally dislocating, and he got better. And I think his neural symptoms were, because he was so skinny, he was getting some tuberous tunnel syndrome, which I gave him some advice on that, and that totally settled. And he's back in the gym, he's putting on muscle, and he's just gone back to his college course. So they tend to improve really, really quickly. So going back to this lady, she's probably one of the most difficult cases I've treated, and it's a learning curve, and it's really just kind of point out where my limitations are. So she came to see me having had physio at another hospital. And she said she'd reported years of shoulder problems, not felt right for years. She was quite a high level dancer, and she'd done street dance for 9 years, and reported jolting and cracking. In terms of developmental milestones, she'd walked at 10 months, she'd crawled. That's the other thing we look for. See if they weight bared through the upper limbs. That all seemed normal. She didn't have any dyspraxia. But there were a few kind of warnings in terms of she had got in with a bit of a bad crowd at school. The mum wasn't very happy with the boyfriend that she'd got. She'd left a previous school due to bullying. There was bullying in the new school. And so there is kind of this background of some psychosocial issues going on. As you as you can see by the movement, she wasn't particularly lat dominant, she wasn't particularly pec dominant, but she had this kind of gross scapular dyskinesia. But then she could do really high level functional stuff. So she was doing the ropes and trapeze, she could dance, but get her to move her arm away from her side, and this is what happened. And so my kind of normal muscle patterning stuff just didn't seem to work on her. I got some advice from Joe Gibson at the upper limb unit. We looked at the angels in the snow and more of the developmental stuff, and I started to work on kind of re-education of the rolling movement, which helped to get some disassociation of her trunk up into her thorax. I also looked at her thorax stability, and we kind of got a little bit somewhere, and then she would DNA and not turn up, and then the next time she came, she'd started with panic attacks and anxiety, and pain was going through the roof. And so this was kind of an example that it made me think about the other drivers of shoulder instability. And so I think the things that tend to be more amenable to the muscle patterning type physio, if there's been an associated growth spurt and their muscles just kind of haven't caught up with the skeleton, if they've got hyperlaxity and they've just got generally reduced proprioception, if they've got any associated muscle weakness or just reduced control, if their sports or their hobbies are having any influence, these are kind of all things we can influence, and the posture. It becomes more complicated when you start to think about central control and drivers to muscle patterning. And this is kind of a whole other area altogether. I'd point people in, I've put some reference at the end, but there's a fantastic article by Kathy Barrett, who talks about this in more detail, and it is quite complex, but essentially we're kind of looking at other drivers. So whether it's developmental, so the questions I tend to ask are, did the child crawl when they were younger? Did they learn to weight bear through their upper limbs? Did they have normal developmental milestones, so such as tying shoelaces, riding a bike? Or is there any indication of kind of sensory motory processing delay? The emotional factors, so fear, stress, anxiety, we all know these can be drivers for shoulder instability. It's kind of a physical response to an emotional underlying problem. Looking at the kind of dysfunctional pain neuromodulation. So any patients or children that present with pain or abnormal sensations, spiders crawling, hyperalgesia, again, it starts to raise my concern. Altered sensory input, so they don't know where their limb is in space. When you touch their skin, they don't know whether you're they can't differentiate. And then any other psychological issues, so whether it's secondary gain, or even I've had a couple of children where, as we've digged into it, there have then been safeguarding concerns. So the shoulder dislocations are sometimes the first physical manifestation of something that's deeper underlying, which is not necessarily a physio problem, but something to be aware of in the wider context. I've just put about the challenge of pain, but again, this is another huge area, but it's really just to think about that when you have pain or disuse of the limb or injury, or how you think about the limb, you can get changes in the representation on the homunculus, and this can give you these kind of weird presentations. And so actually, what does this mean? So you might see things that have identified that give you change at somatosensory level. So for example, they have an inability to discriminate between their left and the right hand. There's a laterality app where you can get them to do a game and see whether they can distinguish. They might have reduced 2-point discrimination sense, which again is something that can be fairly easily done in clinic with the ends of like little point, I can't think of the name, paper clips, that's it. Stereognosis is the other one that's quite a good one to do. So I get a tray and I put objects, or I get the patient to do it at home and see whether they can recognise the objects. So, and if they can't, again, you're thinking more of a central processing issue. And then it can also be an issue with the cervical spine and eye control as well. So it's really just to get you thinking. I've put the puzzle piece in just to kind of, this is how I feel about shoulder instability a lot of the time, is that I kind of have one piece of the puzzle, but actually there's a lot more to it. And I think I'm learning all the time and kind of putting the pieces of the puzzle together. But I think in those patients, you're thinking about getting MDT involvement for sure, and whether there's whether they need pain clinic, psychology, or even specialist input at the Stanmore unit in London. I don't know how I'm doing for time. I'll run through this fairly quickly. So the other things we see are scapulothoracic crepitus. So that's kind of clicking and clunking, or otherwise known as a snapping scapula. And it can be quite audible and give the child quite a lot of pain. You can get this grating, and it's essentially caused by inflammation around the bursa. It's very, very rarely caused by any osteochondromas or anything like that, and they don't routinely CT for this now. So when they come into clinic, if there's no kind of traumatic history, they'll generally go to physio, and this often seen with associated conditions such as scoliosis and kyphosis and dyskinesia, but they typically get quite a crunch. And so they might represent, you'll still see a winging scapula. Just thinking about the associated anatomy, so you've got your serratus anterior, which helps to flatten it, and also the trapezius. And so just to kind of differentiate between the true thoracic winging, which is where you get gross winging of the medial border of the scapula as the arm is elevated. These are very, very rarely seen. I think I've only seen one Parsonage Turner in a child, well, an adolescent, and then one long thoracic nerve palsy after an injury. So they're really rare. And then the S8HD tends to present a little bit later on. So I don't think you'll see, if any of these, I think I've seen 2 in my career so far, they tend to happen more in adults, but you will get the gross winging. We tend to see the pseudoscapular winging, which can be secondary to shoulder instability or pain, or just abnormal functioning of the scapulothoracic muscles. So it's very similar to your type 3 patterning, really, that you would look to see whether you can improve their symptoms. So by scapular shrug, so getting upper trapezius to activate. If you think back to the video where I was facilitating the scapula, if you get them in that position and get the serratus anterior and upper traps working, or even get some posterior cuff activation, does that reduce or get rid of their symptoms altogether? And then I'd look at strength testing. So do they have weakness so they can't physically hold it there, or is it more of a fact that they're not activating it? If they're not activating it, generally you can change them pretty quickly. So this is an example of a girl we saw in clinic. So she was referred, she'd had some really good physio, lots of posterior cuff activation, like really appropriate kinetic chain exercises, but just wasn't really improving. So she kind of came with this winging, no kind of obvious psychosocial, was really engaged with physio, willing to try again. And then this was her doing a wall press up. So I was on the verge of getting her nerve conduction studies, because I did think this is like a true winging. She's got some nerve involvement here. But actually, I sought the advice of another upper limb specialist up in Liverpool, and we got her just doing some upper traps work, and she was much improved. So just, I think you can see here her trapezius are not really firing. So we got her to do a shrug, then with some posterior cuff work, and it eliminated all of her dynamic scapular winging. But she was quite an interesting case. I don't think I've seen anybody with that profound winging. It was caused by a dynamic problem to date, really. And then just a little bit on atraumatic SC joint instability. So we use the Stanmore triangle to inform decision making, so very similar. They present with clunking and visible subluxation of the SC joint with and without pain. the relevant anatomy is related to the pectoralis major and the SCM being overactive. I don't know if you can see this video. It's here that it happens. So you can just see her SC joint pop, and she's got some overactivity in her pecs and a sternocleidomastoid as well. And so rehab's very, very similar to the to what we do for shoulder instability. So you get the cuff working, you work the kinetic chain, you get them doing, you can still see there she's a little bit dominant neck, but that was just within the first session within clinic. But typically risk factors, scoliosis associated with glenohumeral joint laxity, connective tissue joint disorders and joint hypermobility, slump postures, scapular dyskinesia, and the overactive pec major. And essentially, you're doing the same bits and pieces as you would do with your movement improvement, but just thinking about a neutral cervical spine with it. So essentially, if no trauma, you rarely require investigations. Consider the Stanmore classification to guide management, and definitely physio is the way forward to input to correct abnormal movement patterns. Don't over-medicalise hypermobility, and definitely consider pain clinic and wider MDT input for the patients that you think there's kind of more central drivers. Investigations will be EMG, nerve conduction studies, and then of choice the MR arthrogram or CT arthrogram, and then the gold standard would be an arthroscopic examination. And there's just some bits and pieces reference wise. So thank you very much.